My name is Tim Ria, host of Digital Health Live here at CES 2015. The crowd is roaring. So we're actually in the back of an 800-person event that's happening on, and we're grabbing really cool speakers and people, personalities. Mike Cantor here is from New England, and your company's New England Quality Care Alliance.
We're the physician network for Tufts Medical Center in Boston. We have about 1,800 doctors, 600 at Tufts, and the rest in communities around Boston, up north to Lowell, out west to Natick and Framingham, down south to Cape Cod, Plymouth, Fall River, New Bedford.
What's your background?
I'm a geriatrician and a lawyer, actually. So I've been really concerned about areas where law and medicine intersect that don't involve malpractice. So trying to focus on things like understanding how to ethically take care of patients. How do we build better systems of care? How do we manage chronic illness, which is what geriatrics is all about, and do that in a way which contributes to our 4 overarching goals, the goals of better health, better care, lower cost, and improving provider satisfaction. Because if the physicians and our teams don't feel good about what they do and are burned out, we won't ever get to those first 3 goals.
Cool. So drugware, pharma rises beyond the pill. We've had companies here, Proteus Digital Health, and it's a really interesting space between pharma and silicon.
Yeah, and that's the thing is we now will have the opportunity to actually gather data directly from patients using these sensors and monitoring devices to understand the impact of medications in a way we've never been able to before. We'll be able to make adjustments more quickly. We'll be able to understand the impact on the body's physiology more quickly. My challenge as someone who works with a lot of physicians is to understand how is this going to fit into the workflow. So we have doctors and nurses and pharmacists who I work with to try and improve care for patients and provide the comprehensive care that people need. Their workflow isn't set up. Their electronic health records aren't set up. How do we understand and make it so that this fits into the traditional approach of diagnose and treat, which is what doctors do? They see a problem, they diagnose it, they treat it. They order tests, they order medications. Where does wearing a monitoring device along with the pill that you're taking or the patch you're putting on your arm or wherever on your body, how does that fit into what we've always done with patients? That's the challenge that we're working on at the New England Quality Care Alliance.
The hard part is we get these shiny new ideas and technology, but really there's a lot of hard work to fit those down to the end customer, the doctor, and then all the details in between. What else did you find that was really fascinating on the panel, and who was with you?
So I was there with Rav Sheth from MC10. So they make these flexible patches with incredible technology inside that can sense motion and muscle activation and a whole bunch of other things. And with James Zackheim, who's from UCB, which is a pharma company that makes Parkinson's medications. Parkinson's disease is characterized by tremors or shaking. So if you put a patch on someone's arm, you can actually measure how much they're shaking and what the muscle activation is like underneath that. So you can time, here's the onset of the drug's action. Look, the tremor got better, or it didn't get better. We need a higher dose. I mean, they're just beginning to try and figure this out. And what I'm trying to do is figure out, so how do we get these things now before they're ready? Begin to lay the groundwork, understand how they work, how well it fit into the role of a neurologist or primary care doctor, trying to adjust medications for those patients.
Is there like an ontology or a database of symptoms and then the biofeedback that...
This is another problem is doctors and our teams, doctors, nurses, and others, if you start flooding us with data and we have no idea how to make sense of that, there is no playbook you open up. Like now, if I'm taking care of a patient with diabetes, there's certain laboratory tests, the blood sugar level, they call the A1C, which is an average blood sugar level. I know how to interpret that. If this is over a certain level, I know what to do to adjust their medications. If you show me that the activation of the arm muscle has increased 32% or decreased 32%, I don't understand yet. Exactly. I was talking with a cardiologist after the panel, and he was talking about how these sensors mean we understand much more about the cardiac function minute to minute. What we don't understand is how those different changes, when does it cross the line and something I should be worried about? So there's a lot of science that has to be done in addition to the practical issues that I work on. There are basic scientific and medical and clinical questions that we still have to answer.
And then you have to attenuate the noise and put a buffer so you're not overloading the doctors.
Correct. We need to figure out how to filter the data. We need to figure out how to take that filtered data, which is information, right? Red, yellow, green. Problem, okay, don't worry about it. And we need to build the team so it isn't the doctor dealing with the normal data. No doctor needs to see the normal data. the nurse, the pharmacist, whoever can work with the patients on when things are okay or maybe a little bit off. Only when it gets to kind of that more critical level does the physician need to be involved. And given the shortages we have of physicians and the costs that are incurred when you work with doctors, it's really going to be great when we can figure out who they actually need to see and who they can actually benefit.
So where is all of this coming together, and what are some interesting use cases and learnings coming out of trials or experiments?
Well, it's still early days, and the technologies aren't necessarily that new, but understanding how this is going to fit into clinical medicine is what's new. So the work that we talked about this morning with MC10 and UCB, looking at Parkinson's patients, understanding how to use that data to adjust their therapy, that we see is potentially quite promising. In diabetes, they've been using insulin pumps for many years. That's been probably the first example of where physiologic change triggers a response to the way the pump delivers the insulin. That drives down the blood sugar level, but not with these huge swings that people have problems with if they're just injecting insulin and it's being absorbed from the skin. That's really where the opportunities are for the future.
So CES is a global event. There's a huge amount of people here. What are you looking for in terms of connections or folks here?
I'm trying to figure out what's happening, and both from a personal level in terms of, I walked on the floor earlier today, and there must be 15 or 20 companies selling motion trackers, activity sensors. How do you measure your pulse oxygenation? What's interesting to me as a physician is I'm not sure we need all that data.
That's what I was curious is when does where does the rubber hit the road there?
Right. I was talking to a company. They can measure body fat with a wristband, right? So it's not ready quite yet. So I said, how often do you actually need to measure your body fat change? How long does it take you? It's not going to be one day. It takes about a month to actually see a meaningful transition from where your lean body mass versus fat. So consumers don't know that. Even doctors, I don't understand that. I just know it's more than one day, and why would I want a daily measurement of something that isn't going to be moving for at least a month? And there's a lot of questions that sort of come to my mind, and doctors by nature are inherently skeptical. So how is this going to be useful to someone, and why should I pay for it is sort of the other question.
Yeah, I know. I'll drop his name. Wainwright Fishburne during dinner last night was saying it's our responsibility as a group here to tell the story, but really, tell it in a way that's not selling snake oil and having devices that are actually legitimately doing something.
I would agree, and I think again, it goes back to understanding what are those algorithms to actually make sense of the data. So if I understand I walked 472 steps an hour today, and I only walked 275 yesterday, what's the right number of steps? Or is there a right number? Is it just higher or lower? I don't think we understand what that means. I think that's why a lot of people stop using those devices. It's like, okay, I didn't make it to my 5,000 steps for the fourth consecutive day. I'm not going to do that anymore. You could adjust the step threshold, by the way, down, but most people don't understand how to do all that. And if the value is really to drive up exercise and it's telling you you're not doing that, that's not reinforcing.
Yeah, but we do have to experiment. If you don't try, and these entrepreneurs aren't trying new things, but we're going to start to see what works and what consumers actually can do with the data. It's not just, I have 2% body fat or whatever it is.
What works apparently is aligning the incentives so that there are financial incentives or health incentives that are more directly felt by the patient or consumer, and the socialization of it and gamification so that people can compete with each other and they say, oh, I took more steps than my cousin, so I feel good about that. That's what's coming next. How that fits back to the healthcare system is what I'm worrying about. And I don't know yet. But I'm trying to figure out, so what is it that we're going to be faced with? Because when a patient comes in to see you and they say, oh, I've walked 18,000 steps this week, what do you think? Great.
Yeah, what's brilliant is Gilbert's put together the pieces of the puzzle in this theme and story, and then you'll meet the people that are actually creating the edge of this technology, and then folks like yourself who can actually make it work.
Exactly. Most of these technologies will be used for people who don't need to see their doctor on a regular basis. There will be specialized technologies for people who have chronic illnesses where those data need to be reviewed by a healthcare professional in an ongoing way. What that line is between the professional level and the amateur level, if you will, we're still experimenting, and you can see in the floor how these things are beginning to converge as well, because the technology is cheap enough that an amateur can get the same kind of blood oxygen measurer as they're using in the ICU at the hospital down the street. And it's only a couple of $100 to do that. Is that a good thing, or is there something where we should be saying, that doesn't really matter for you anyway, as long as you don't have emphysema or whatever, your oxygen levels are going to be fine?
Cool. Well, hey, it was fascinating. How do people connect up with you?
They can reach me. My email address is mcantor, MCANTOR, at neqca.org.
All right. Well, thanks so much. Fascinating to have you on the story, and I will definitely connect with you personally because you seem like you know what you're talking about. So thanks for being on the show.
You're welcome, Tim. It's very nice to meet you, and I enjoyed it.